Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center, and I'm also the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our topic tonight is health equity and health disparities. And our guest is Corey Dion Lewis. Welcome, Corey.
Thank you for having me. It's an honor.
Corey is the clinical health coach at Broadlawns, and we're going to get to know Corey a little bit, and then we're going to talk about this very important topic of kind of health in general, but also health promotion, health coaching. How do we, the best way is to try to prevent cancer if we can prevent cancer.
Absolutely. I'm for it.
So where are you from originally, Corey?
So I tell people I'm from East Moline, the Quad Cities. Okay. But if they know where the Quad Cities is at, then I tell them where I'm really from. That's Silvis, Illinois. Because Silvis is right next to EastLine.
Okay. How big is Silvis?
Silvis is like this big. Like it's not very big at all. So everybody thinks it's by Chicago. Like, no, it's just right next to East Moline.
And where'd you go to high school?
I went to United Township High School in East Moline.
Okay. Mm-hmm. And was that a big high school?
Decent size. I mean, not as big as you see here.
How many
in the
your
metro
graduating class?
So there's probably about 360 something in my graduating class.
And what was your claim to fame in high school?
My claim to fame? Oh man. So, I played sports growing up. So, basketball and track were my thing in high school. But I guess my claim to fame was I had to share it with my three best friends, and we dressed up in dresses and wigs the last day of senior year. So,
and you're forever remembered for that.
Forever.
Is there a picture of that in the yearbook?
Not in the yearbook, but there's a picture that gets shared almost every year.
Okay. And then when you graduate from high school, what did you do next?
So after that, I went to Kirkwood Community College in Cedar Rapids, and just focused on my school, and the goal was to graduate and so I went on to University of Iowa after that.
So you got an associate's degree at Kirkwood, excuse me.
Yeah.
And then went to the University of Iowa.
Yeah.
And what was your major?
So my major was in interdepartmental studies, but with a specialization in health coaching.
Okay. Mm-hmm. And what type of classes did you take as, a health coaching major?
Yeah. So as an interdepartmental studies student, I had classes all over the campus. So I had a lot of counseling classes. So I would do motivational interviewing in one department. Then I had some social work classes, but I also had nutrition and human anatomy. So it was all over the place. So a lot of human anatomy, a lot of biology, statistics, nutrition, things like that.
Mm-hmm. And then when you graduated, what was your very first job out of college?
Yeah, so my very first job was not a coaching job. It was at It was at Orchard Place here in Des Moines. Oh, yeah. I was a treatment counselor I was a primary counselor for 1 year, but total 3 years I worked at Orchard Place.
Right. And what's the age of the clients there?
Age of the clients, I want to say they age out at 17.
Okay, so it's definitely pediatric. So
yeah, so it's like I think in the house that I was in, I want to say the youngest was probably 9 to like 15, 16.
Mm-hmm. And now your current job, as we said, is a health coach, clinical health coach at Broadlawns. So why does a hospital or a health system need a health coach? Do you have your own basketball team?
No, I wish that would be so cool. If there's a basketball team.
So tell us, but really what I'm asking you is, what is health coaching?
Yeah, so when we're looking at health coaching from a clinical perspective, it can be numerous things. One is it's more time and care for the patient, right? So, doctor, you may say, hey, I want you to focus on these behaviors, but you only have so much time to be able to work with that patient. But being able to have a health coach a part of your care team, I can work with that patient for 30 to 40 minutes weekly, every 2 weeks, or monthly, depending on what they want, what the behaviors we're trying to change. So a lot of the things that I focus on with patients are not necessarily what behaviors we got to change like right this second, but what are some of the behaviors that you've learned over 20, 30 years that we have to break down to really focus on some of these goals. Mm-hmm. So, yeah.
Related to like nutrition, physical activity.
Yes.
And even just smoking cessation,
diabetes management, hypertension, things like that. And a lot of my conversations really aren't about, you should eat this many vegetables or this many fruits. It's about what were your eating habits like when you were 10 or 11. Well, I couldn't leave the table until I finished all my food. Well, now you have that same behavior now as a 60-year-old person, but you don't need that. You can stop when you're ready. So we focus on a lot of that, and we focus on a lot of um outside of the, like, some of those social determinants, things that you don't really think about,
Mhm.
that we focus on too.
So, in the world of cancer, we call some things modifiable risk factors. So,
Okay.
50% of cancers in the United States are caused by modifiable risk factors: diet,
Hmm.
exercise, sunscreen, obesity, alcohol intake, cigarette smoking. All of those are modifiable risk factors, and all of those would be things that would be prime for a health coach.
Absolutely.
Right. So, as a
Yeah.
doctor, I might tell my patient, well, you should stop smoking. And then, I got to get through and in 15 minutes, a whole bunch of things. And then you sort of leave it at that.
Yeah.
Whereas a health coach, you schedule probably a much longer amount of time
Longer
to meet.
visit, and we can get right to the thick of things, and it take as much time as we need.
And do the patients that you see, do you see them while they're seeing the doctor, or typically do they schedule a separate appointment to come to see you at a different time
Yeah.
in a different location?
It's a mixture of both. So there are times where the provider will say, "Hey, I have this patient coming in that I want you to see them," and they'll see the provider, and I'll go in after their visit and talk to them and give them some information. But the majority of the time, they're scheduling an individual appointment, and I'll see them in my office.
Mhm.
Hmm.
So one of the problems, or one of the barriers to everybody getting healthy, is it's time consuming,
Yeah.
to get the coaching and to follow through with it. And sometimes the healthiest way of doing things can be more expensive than other ways of doing it. I'm sure that that's one of the issues you address in terms of nutrition.
Yeah, and that's one of the barriers that patients tell me all the time. I want to get healthier, but have you seen the prices of fruit, or have you seen this? And that is a challenge. That's a real challenge. I can't deny that. And given the population that I serve, I do see a lot of patients that maybe are on food assistance, or they can't afford to eat what they deem as healthy, what they're healthy, or their idea of healthy. So my goal is to, one, figure out, okay, how can we improve their diet in any way, shape, or form. Maybe it is adding, not adding fresh fruits and vegetables, but maybe frozen or canned, but rinsing off the high fructose sugar or the salt that's on those, on some of those, or just connecting them to food pantries that have healthier options, because they're out there that maybe they just don't know about them. So just trying to figure out, okay, how can we make the best of their situation to get them the healthiest diet that they can.
One of the things that is not surprising when you know anatomy, physiology, and kind of the root causes of many disease, that fortunately, when people want to know what are the healthy diets, what's the healthy diet to prevent cancer, what's a healthy diet to prevent heart disease, what's a healthy diet to prevent diabetes, that pretty much it's the same diet. And so you don't have to memorize like
Right.
12 different diets for each chronic disease of the patient you might be seeing. I mean, some would have some special needs, perhaps,
Right.
somebody in renal failure might have some different needs. As part of your training in college, was nutrition part of that, or have you learned most of what you know about nutrition and coaching on nutrition something that you've learned after college?
Yeah. So there is a lot of education on nutrition in college, but I will have to say I learned a lot of it working with patients at Broadlawns, not only because, people have different needs, but also I'm working with different cultures.
Mhm.
So their cultural foods are different than what I would eat, so I'm never going to tell someone they shouldn't eat what they're used to. So just really learning, okay, how can I work with everybody? And now I'm asking better questions, like, if I'm seeing someone that is Karenni, or from a different culture than I am, what foods do you eat in the home, and things like that, so we can make those healthier. Or maybe they already are eating pretty healthy, they're just eating, their caloric intake is too
Mhm.
high, so it's just an increase there. So just trying to figure out what that best is. But also, I don't prescribe diets or anything like that. I do give recommendations based off of evidence and research. So I recommend the DASH eating plan a lot, Mind, things like that,
Mhm.
but never will prescribe
Mhm.
someone like a specific diet.
So I imagine someone with diabetes who might be seeing internal medicine for diabetes control. There probably are nutritionists as well, or
Hmm.
dietitians that are on the team. And your job is not necessarily to tell them what the diet is, but to help coach them to how to accomplish that
Yes.
in real life.
The way I put it is the dietitian gives you the directions, the health coach gets in the seat and shows you how to get there.
Mhm.
So I don't necessarily tell you, hey, you got to turn left here, you got to turn left here, whatever. I get in the car and say, where should we turn based off the directions that you got, and they don't know, then I will come in and assist and give some techniques and some different tools in my own tool belt to make sure we're successful.
So we talked about nutrition. Talk a bit about physical activity. We know that physical activity is very important
Yeah.
in helping to prevent many diseases, including cancer, but also to help control chronic diseases. What would be a typical conversation with one of your clients
Yeah.
around the area of physical activity?
What's interesting about physical activity is that people, when I ask a patient, when I say exercise, what do you think? Is usually I gotta be at the gym, I gotta do all of this, and I just can't do it. And it's like, well, you can walk. Like, walking is so underrated, but the evidence shows us walking is
Hmm.
very, very good for us. So what's recommended is 150 minutes of moderate cardiovascular activity per week. So that's what I recommend. If you can do more, great. And a lot of it is when they hear that, they think they have to do it all at once. Well, you can do 10 minutes in the morning, 10 minutes,
Right.
you can break it up.
And vacuuming and
Yes.
mowing, those all get to count as
all
exercise.
all count.
It's not something that just
Yeah.
happens in a gym.
Now, I think now it just happens in the gym, but I do separate the two. I do separate exercise and physical activity, which all works together. So if someone's mowing or cleaning the house, that's great physical activity. But just for some of my patients, I do say, okay, what are you doing for exercise? 'Cause I want to make sure they're creating a mindset of, okay, I need to set out 10 minutes of my day, or five, whatever it is, where I am walking, or I am going to the gym, or I'm watching this YouTube video and dancing to it, whatever that is.
Mhm. Um, Besides nutrition and physical activity, what are some of the other life activities that you spend time coaching with your clients?
Yeah. So a lot of my time is focused on behavior change. So behavior change strategies to get them to really what we're talking about diet, or we're talking about exercise. And some of them have maybe a poor some of the things that we can do to make that easier and more consistent. So I'll give you one right here. So I may have a patient that wants to start walking in the morning. So we'll do they're called if then statements. So if I have my shoes by my bed, then I'll go for a walk, right? So really getting those things cemented in their brain. So every time they see their shoes in a certain area, they go for that walk. Like for me, if I set my coffee pot in the morning, that no matter what, I know I'm going to get up at that time because I set my coffee. So I know I get up, I have my coffee. So really getting them to get into these behaviors to make the activity easier for them.
Right. So some of those cognitive behavior
Yes.
changing things,
Mhm.
you can use it for whatever behavior you're trying
Yes, or
to
habit
modify.
trackers. Habit trackers are great. Having a calendar, setting a goal. I want to drink water every day. Every day you drink water, you put an X in that day. And then when you see all those X's over the month, you see yourself building this new behavior. So it's all about just tricking your mind to know getting into a new behavior.
So one of the things that can be helpful with habit forming is accountability. That you,
Absolutely.
yeah. So do you follow patients? Do you Are you involved in any sort of apps where you track them? Do you check in with them by phone or by various forms of different devices, or how do you
Yeah.
help with that accountability to help them establish, ingrain, and you really cement habits?
Yeah, the accountability piece is probably the out of changing the diet or exercise is probably the best one because they know, oh my gosh, I gotta see Corey in a week. I can't have this donut that I really in their mind. I don't care if they have the donut.
Mhm.
Like I want them to make that change, but I'm not going to. I'm not going to punish you.
Mhm.
You know what I mean? But in their mind, there's this app I use. It's called Fat Secret. It's a free mobile app, and they have a health professionals platform. So whenever my patients track on the app, I see everything they're eating.
Okay.
So they're like, I can't track them.
So whether you're actually looking at it or not, they think they're
Yes,
gonna bite this donut and you're gonna know.
yeah, I'm going to know. And they're like, oh my gosh, I can't. Or and it's like
Hmm.
it's funny. We laugh about it, but that just goes to show the power of accountability,
Hmm.
right? Is knowing like, oh, I am accountable to someone else, therefore I have to be on my A game.
Hmm. Let's transition a little bit, because one of the reasons that we wanted to have you as a guest is you've got a conference coming up, and it's
Yes,
called My City, My Health.
yes,
And it's focused on, I would say, what I would call social determinants of health. And
yeah.
I mean, how would you describe to the public what social determinants of health and how that factors into health coaching?
Yeah. Well, social determinants of health is are the factors where we work, live, play, and pray, right? That affect our health. So the way I kind of incorporate that into my health coaching is, I may see somebody that would like to improve their diet. But like I said earlier, with the population that I serve, or the majority of the patients that I see, they may be on food assistance, but also they're at the mercy of the closest food pantry. And some of them are in food apartheids or food deserts. So they don't have a lot of access to healthy foods, or they don't have transportation, right? They would love to eat healthy, but they are in walking distance to their closest gas station and they can't get to the closest grocery store or things like that. So when I'm coming to social determinants health and health coaching, I've really meshed the two of those to figure out, okay, how can I help all of my patients, no matter where they're at, no matter what social driver
Mhm.
is affecting their health, how can I help that? And with My City, My Health, it kind of came from that kind of a situation. So outside of what I do at Broadlawns, I do have a health equity media company called The Healthy Project, where we do the Healthy Project podcast and things like that. And we had some really good success with the podcast. But I had a patient, a Latina woman, who I was seeing there. She was pre-diabetic. And she came into my office one day, and usually she's very bubbly, very excited because she was doing really, really well. And this one day she wasn't. She just wasn't herself. So after our session, after we go over everything, I asked her. I said, "Hey, how are you doing?" And she goes, "Well, my husband just lost his job, and I don't know how I'm going to pay rent next month." So that I'm like, oh, so but luckily I had some resources. There's a platform that I used, typed in her zip code. I found some resources and was able to get her, connect her with a company organization that helps people with rent assistance. And she was able to get rent assistance for that month. And you can just see the weight off her
Mhm.
shoulders. And that really was kind of the man. It felt good to help somebody, right? It always
Mhm.
feels good to help
Mhm.
somebody. But what are other people doing? Like, what can we do for our community? So the goal was to have all the people in our community that are doing the work. Let's come together and have these conversations. And how can we continue to do the good work in our community? And that's where My City, My Health came about.
And what are the topics that you're going to be addressing at this conference? Well, first of all, tell us when the conference is.
Yes. So this will be our third year in Des Moines. This year's conference is November 15th at the River Center over there by Principal Park.
Mhm.
The conversations we're having this year are around maternal health. We have a mental health panel. Everything's panel driven, so it's all different panels. So a maternal health panel, prevention panel, mental health panel, health equity at work panel. We're noticing that work plays a huge role in somebody's health.
Mhm.
So we're having that conversation, and we're having an inclusive healthcare panel. So all great people, just having great conversations.
And anyone can attend. Is that
Anybody
correct?
can attend, and what's been so cool about it, it's almost like the community comes out. There are a bunch of people that aren't even in healthcare or public health professions that just come to learn or get their questions answered. We have a really great Q&A after the panel with the community or with the audience, and that's almost better than the panel itself sometimes. Just the questions that
Right, to get the real, what's really bugging people, what's really affecting their lives.
Absolutely.
And how would someone sign up for the conference?
Yes, so you can go to the website at mycity.health, and there you can see the panelists. You can see more about who we are, and get your tickets there.
Okay. And again, that is November 15th.
November 15th.
And is it an all-day conference? Like
8 to 4:30.
8
So
to
yeah, all
4:30?
day.
Yeah,
all day.
What are you most excited about in this conference? Like, is there a speaker that's going to be on a panel that you haven't yet heard or that you're excited to hear again?
Yeah, so I will have to say I'm excited about all of the panels that we're having. You know, I had a hand in kind of figuring out what conversations we're having and who we have. I kind of curate who's on the panel. But what I will say, I'm really excited about. We do have our mental health panel is probably one of our most popular panels. In those conversations, we just have some really great speakers that know what they're talking about, but they're very charismatic, so they just really know how to talk to an audience. So I'm really excited about that panel, and honestly, it's just fun. So I'm just excited to be in a space where people feel safe to be themselves and to be to speak their own truth and to educate others. It's just a fun time.
And this is the third year you're doing this here in Des Moines.
Third year in Des Moines.
Can you point to any policy changes or programs that have come out of or been modified because of the previous two conferences?
Oh no, I can't. I would love to say that I know, but that you brought up a good point. You know, it's one thing to have a conference and everybody feels good and getting this education, but what are we doing after the conference? So I think,
hopefully people who attend might do, things to modify the way they're interacting.
Yeah. And we've had
not
people
necessarily come up with a brand new program.
Yeah.
And try to get it funded and put it into place
right
in a year. That doesn't happen.
And we've had people be able, the great thing about our conference here in Des Moines, and we had one in Iowa City, we have one in Minneapolis as well in September. But the great thing about it is we're able to connect people who would have never connected before because they're just not in the same circles. So we had someone had the opportunity to get a grant from Delta Dental to give books to underserved kids about brushing your teeth, and the books looked like them. They were kids of color. So that would have never happened if they weren't there, if they weren't heard the Dr. Harvey, who was on the panel, talk, and they saw, oh, Delta Dental's here. Oh, I would love to. I do this, and able to make that happen. That would never happen. So that I can say that was really, really cool to hear. But as we talk about health equity, social determinants, policy is important. So really thinking, okay, with this, as we continue to make these steps, what does this look like for us, and how can we move the needle there?
So if you had a magic wand and a limitless budget, how would you change healthcare in Des Moines, Iowa, to make advances in having Des Moines be healthier?
Okay.
And maybe before you answer that, what are the parameters by which you would judge if Des Moines is healthihier?
And this is live and recorded. Okay.
Yeah. Yeah, and I've got
So there's no turning back. There's no editing this one out, right?
well, realizing that you're just kind of thinking out loud.
Yes.
You're thinking out loud.
Well, yes. So
You'll
what?
get a chance to modify the grant before you submit it. For
Right.
funding.
The one thing that I would love for healthcare to focus on is we talk a lot about social determinants of health, but do we really are we walking the wall? Are we putting our
Right.
are we really doing something about social determinants? So here's one. Housing is a big one, right? Something I read years ago. So if I had a magic wand, I would make housing more affordable, because we know when people have more affordable housing, they are healthier.
Right.
So, right.
Yeah. But I bet your healthcare system and my healthcure system are not going to
They're not
accomplish
thinking about
that.
that.
Well, I know
Thinking
even we're
about
thinking about it.
Yes.
Whose desk does that fall on? Who is responsible?
Right. But
for
my magic
creating-
wand would just make that
It
happen.
would make it
you know?
Okay. So housing, very, very good point. So maybe back to that, what are the parameters by which we would judge whether Des Moines is healthier? So let's say housing is affordable and that everybody has the ability to be housed.
Yes. And I would think you would be able to measure, okay, how has this improved our homelessness? And is there a correlation between homelessness and ER visits? If you're home, that's where you're going. It's an ER. And what does that look like? So
Right.
is there a correlation there?
So these are very different things than saying we want our A1C to be low.
Yeah, we want to be below 6 or whatever.
Measuring a healthy population and a healthy city, we're looking at things like shelter.
Yes.
Food security.
Yes, transportation.
Big
one.
Yeah. Income.
Yeah, absolutely.
Yeah. Education.
Educate. All of it.
Mm-hmm.
Right. So it's really kind of hard to just nitpick just one, right? Because all of it plays together.
And we're talking about this being health, but it's not all under things that a doctor and a nurse are going to fix.
Right.
Or a health coach.
Or a health coach. Yeah.
So we got to have systemic
changes needed.
Private,
yes.
Public, and health care involved in
Absolutely.
This.
Everybody, and these are not my words, I got this from a friend, but everybody is a public health professional. No matter if you work in the healthcare system for a public health system, or if you work down the street at Hy-Vee, you are in public health. So how can we all make a change for everybody? And we can. There's a way we can do it, right? I'm an optimist, so I know the glass is half full for me. It's just thinking outside the box a little bit,
right? And healthcare. I know we're talking about health, which is different than healthcare,
right?
Because part of it is lifestyle that keeps you healthy, but healthcare is so expensive. And I was just at a conference that the American Cancer put on the financial burden that cancer patients go through, even if you've got employer provided good health insurance. Most of those, not only do you contribute every month, but most of them you're going to have $10,000 to $15,000 of out of pocket, and an expensive type of disease like cancer, you're almost every year going to have that. So people that are lower or middle income that even have good health insurance still run the risk of bankruptcy just from the year after year of out-of-pocket expenses.
Yeah. So, I mean, just think of what that does to you stress-wise, and just think of, I'm sure you know what stress does to your body. So not only are you battling something that is killing you, you're battling the stress of this bill. So it all plays. It's just a vicious circle.
Yeah. So I thought maybe with the magic wand and unlimited budget, you would have a one payer healthcare system.
That's a good one. Well, if I had some more time to think
Okay.
about it.
Okay. What are other things in terms of thinking about my city, my health globally, would you encourage us to put some time and effort into? So there's the thing, like you and I every day, we might, see 20 patients and we have the opportunity to change the lives and health of 20 patients. But when we talk about public policy, we might have the opportunity to affect,
Right.
600,000 people if we're talking about Des Moines.
Yeah, and I think when I'm thinking about that, what comes to my mind is prevention, right? So what are some of the things that we can do from a policy standpoint to make, for some cancers, people, I keep hearing people, our kids are not kids, but adults are getting cancer younger and younger, right? But some of these preventative measures, you got to wait until you're 45 or 50 to get them. So what does that look like from
So here's one: HPV vaccination, ages 11 to 13. We're like way less than 50%. These prevent 6 different cancers, and they're provided, free of charge vaccinations.
Right.
And so that's one thing that we can do to prevent cancer.
Absolutely.
But we still, there it comes down to then behavior modification. How do we get parents to, be educated to, and then follow through with getting those vaccinations to prevent those cancers?
Yeah. And a lot of that is, making sure, trusting your provider and trusting some of that stuff plays a role too, right? So I don't know what the answer is there. What do you do to make somebody to, when they have years of trauma?
You hit on it. The number one way to get kids vaccinated is to have the doctor say, I really recommend you do this.
Yeah.
But then you're also talking about structural. It helps if the doctor looks like the patient and there is cultural affinity. It's not necessary, but it certainly can be very helpful in the whole trust in such an important relationship as doctor-patient.
Yeah, and but in a state like Iowa, that's always always have that luxury of having someone that looks like you, right? So I just encourage providers to have cultural respect. There are cultures that sometimes don't agree with some of those things, but if you show them respect, whatever form that is, I'll give you this story. How I learned about cultural respect when I started at Broadlawns is I had a Korean patient in my office, a young boy, 9 years old, 140 pounds. And it was the grandmother, the mother, and him. And I'm talking to the mother, and I'm telling the mother, I don't remember my exact words, Dr. Deming, but to them, I was like, your son's fat and needs to lose weight. I didn't say that. But to them, what I said was, I want you to stop feeding your son and make him sick. Because to them, he was eating, therefore he was healthy. So I lost them immediately. Right? Like they did not want to hear anything I was saying. I learned from that. That was 7 years ago, my very first patient at Broadlawns. So it started off really well for me, seeing patients. But
so that respect. I would say another important component is maybe a healthy curiosity.
Yes.
I mean, how many patients from how many different countries do you serve? I'm sure 100, and some of them, I'm sure the first time you hear the name of that country, you're going, I don't know where that is on the globe.
Well, I kept saying, where's the Karen interpreter? I never heard of Korean. So I started there. They're like, the Karen interpreter. I'm like, yeah. Like, you mean Korean? I'm like, oh, okay. So it's eye-opening.
So having a healthy curiosity.
Absolutely. Absolutely. And that only just strengthens that relationship and that rapport between the provider and the patient, because now they feel like, oh, he wants to know more about me. Therefore, I can trust them,
Mm-hmm.
right? And that may take time. They may not take that first 20-minute session or that 20-minute appointment, but at some point, the more you want to know more about your patient, the more they'll trust you, and then they'll listen to those recommendations.
So, Corey, maybe share with us a success story that you have from your days of health coaching at Broadlawns.
Yeah, so I have a great one. This was more around. She was seeing me for weight management. So, a typical patient I get for weight management is someone that went through weight loss surgery or a lap band or something, but didn't really focus on those behaviors, and they gained all that weight back plus some. So I had a patient in my office. I was their last hope, and she told me, like, I don't believe in health coaching. I'm here because my doctor told me to. So good luck. She ended up losing 150 pounds over the year that I saw her. But the first 3 months of that relationship were rough, right? And when health coaching, when we're talking about weight loss, it's strictly weight loss, strictly just talking about weight loss, not if someone's diabetic or anything like that. It's really just being consistent with the little things. But sometimes the little things are very boring, and you don't want to do that. But going back to that accountability piece, she saw me every week. Even when she didn't want to, she was there. And there were sessions where we didn't even talk about anything. We just talked about what was going on in her day. And then I would bring up, how's your diet going? And she lost 150 pounds, and all she did was, instead of getting a whole meal at Wendy's, she just got the chili and a water. That was her lunch. And she focused on it, and she walked her dog every day. And she did that, and she walked my dog. I did it. And next thing you know, she lost more weight than she lost when she previously got the surgery, which was really, really cool to see.
So just kind of sticking to small steps every day. Small steps every day add up. Yeah. What would you say? Is there? And I don't want to be stereotypical, but maybe share with us another cultural story of a different culture that you learned something in the process. You sort of mentioned food, like even trying to talk about foods, and the names are different, and the vegetables might be different, and you don't recognize.
Yeah. Well, I'll tell you one fun story, which I got this hint from. I had a patient from Peru in my office, and I had always wanted to go to Peru. I just saw the pictures, saw it look, really, really beautiful. And I told this patient, like, I would really love to go to Peru. So mind you, she was seeing me for hypertension, like, so high blood pressure. So I had my dash stuff out, everything ready to go for her. We start talking about Peru, and then I learned that potatoes were a huge part of that culture. So I slowly slid my dash eating stuff to the side, and learn more about her culture. And she was really, what was beautiful about it is that when she talked about her foods and her culture, there was a pride there. And I didn't want to take that away from her, saying that, oh, you like that? Well, here's the dash eating plan.
And there are no potatoes on this plan.
There's no potatoes on this plan. So,
and that is the national food of Peru.
Yes. So I didn't know. I learned that talking to her. So I told her, I said, hey, I'm not here to tell you can't have your food. When I was going to. Oh God. But I was like, I'm not here to tell you can't have those foods. We're just going to put some guardrails around them. And that's, she's like, okay. So she really appreciated that you're not telling me I can't have something. We're just going to put some guardrails around it. So and the same thing with a lot of the Asian cultures that I work with. So rice is a huge staple. So I'm not saying you can't have rice with your meals, but do you know what a serving of rice is? So I have a little cup serving so that you can see this is what a serving looks like, right? So you can get a better idea. Okay, this is where I should cut back, not cut out, but just cut back what I'm eating, and then add more fruits and vegetables to my meals.
Okay. Thank you for sharing those examples. We're going to open up to questions. So we have a large studio audience live here in our room. And if you are watching us live streaming and have a question for Corey, please put that question in the comments section and we'll open it up right here. Poon, you're first.
Corey, do you have a group that walks that you can get people to go, oh, I don't like to go out and walk by myself? Do you have like a group that walk at noon or at 5?
Yeah, so there is actually a program called Walk with Ease that we do at Broadlawns. So I don't run that, our other health coach does that, where she'll just at noon. I've had a few patients go and they'll walk. There's a little path kind of they do, and they'll walk together. And there's something about community that's so great. So I think the more you can get involved with community when it comes to exercise, something like that is awesome.
Yeah, that sort of trifecta of being outdoors in nature, exercising with fellowship.
Absolutely.
Hi. I totally get the culture thing because being a Latina, I remember when I got diagnosed with diabetes and my friends are like, hey, we're going to happy hour. No margaritas for me now. So, 12 years later, and then I battled cancer and they gave me steroids. And then it's still a battle because I'm still dealing with the diabetes and trying to lose the weight and all that. And so I did go through exercise groups and things like that, but realizing that can convert to muscle as well. So what do you tell clients about when they get on that scale? Do they need to count on that scale or look at that scale as, are you failing or gaining? I mean, learning anything from it?
So me personally, I don't have my patients step on the scale. And my reason behind that is everything that you kind of said. A person can be doing everything they feel like they are eating well, they're exercising, but if that scale didn't move, it's like none of it never happened. And then next thing you know, they're like, well, screw it, I might as well go to nothing but cake because everything I did last week didn't work. So we track our progress in different ways. So I keep track of what almost like a Facebook memory. Like, remember last week when you told me that you walked for 10 minutes, but today you told me you walked for 30? That's progress. Or, hey, you usually eat fast food on the weekends, but you didn't do that. Like, so I track progress differently, unless someone really wants to weigh themselves. And if you can mentally take that, like, hey, I didn't gain any weight, okay, because it's a great way to measure, right? See where you're at, but it's not necessarily an indicator of how good you're doing or how successful you are. So I personally stay away from it and just figure out other ways to track your progress other than the scale.
Well, another second part to that, being a Latina, I said again, don't take away my tacos. But what do you tell somebody like with my culture that grew up with tortillas and things like that? How do you fit those parameters for that?
Yeah,
kind of
so
culture?
There's two ways. One is understanding that there is going to be some sacrifice when trying to lose weight, right? But what I do is it's called add to, not take away. So if you're having a tortilla, what can you add to that meal that is healthy? Can you have that tortilla with a serving of grapes, with some strawberries, with a salad, instead of a soda? Can you drink that with the water? I always let people know, if you want to stick with that, you can't have the tortilla and the Snickers. You can't have tortilla and the regular Coke. There are choices you got to make because we're trying to get healthier, right? So that is why I usually recommend is add to, not take away. So what?
Thanks. Other questions, Kevin?
Yes, in this podcast, we often talk about the limited number of cancers for which there is a screening test. And I'm assuming that the American Cancer Society, maybe Mercy One, above and beyond, has a profile of who the people are that who take advantage of that test, and who the people who aren't. Is there a program to try to reach out to those people who don't take advantage of those tests?
Yeah. So question relates to screening, and there are 5 different cancers for which there are validated screening, and comes down to the responsibility of the primary care. So most screening is done by people who don't have cancer, so they're not part of the cancer center. So screening is a responsibility of primary care. So primary care is family practice, internal medicine. Sometimes OBGYN can be considered a primary care. And, in olden days, it was all very manual on paper records. Now we're trying to leverage AI and tools of computerization, where whenever the patient walks into the office and their name pops up, you see when did they have their last screening? Are they due? Are they overdue? And, the very sophisticated ones don't just wait till the patient shows up in the office. When it's a month before they're due for the screening, the software already recognizes it and automatically sends them a text or a email or a postcard informing them that they're due. And then you need to have, in the most advanced systems, what do you do if they haven't followed through? How do you work the list of those that haven't followed through? So I don't know if I'm answering your question, but you still end up with a lot of individuals who are not getting their screening just because they weren't aware that they were supposed to, but because they may have difficulty getting off work, they may not have childcare, they may not have transportation, and even though with the Affordable Care Act, there's no copays and deductibles with screening, you might need to take time off to get it done. And so those represent issues. And then there are other cultural issues with certain types of tests and certain types of screening, or someone is just afraid that the screening will be positive and they don't want to deal with that. And then, as you mentioned, mental health just factors into almost everything we do. And that may also be a barrier to attaining the health care you need, even if there's not a financial barrier. What would you add to that, Corey?
I think you answered that pretty well.
Okay.
Yeah.
Corey, do you try to find, when you talk to somebody, do you try to find out if they have had any screenings, or if they want to have a screening? Or
Yeah, well, so a part of my role at the hospital is I do our Medicare wellness exams and visits, so I can see when their next screening is, or if they're due for one. But to your point, if someone's due for a prostate or a colonoscopy, I feel good. I don't want it. And so then I got to probe and kind of I wonder, like, well, how do you know that you don't have anything wrong? And so there's that fear of, like you said, there's that fear of what if they see something? Well, that's a good thing. They see it. Now they can take. Now you can handle it. But if you wait too long, what's going to happen? So yeah, a lot of it within my experience is a fear of the unknown, of finding out.
My question has to do with cost and accessibility, I guess. Are all major insurers covering a health coach like yourself, including Medicare and Medicaid? Is it 100% covered? And I guess the other question is it only on referral from a referring physician, or can I decide myself that I got issues and I need a coach, and can I come to you, and will my insurance pay for it?
So there's two things there. It's two things. So health coaching at Broadlawns is free if you see a provider there. So if you see a provider at Broadlawns within a primary care provider, you can see the health coach at no charge. But right now, you can't bill for health coaching. So, and they're trying to change that. There is some, I think it's I forgot what code it is right now. There's like a research code. I forgot what it is. They're trying to get that to where you can bill for coaching. I have my own. I don't really feel like we should be billing for coaching. Me personally, I feel like it should be free for our patients and not have to worry about if insurance covers health coaching. Like, we should be investing in that. I think it's more of a value. But yes, anybody at Broadlawns can see the health coach if they have a provider there. Currently, health coaching is not covered under insurance.
And the next question is, it sounds like a lot of your service revolves around weight loss and the obesity epidemic. Are you seeing patients now that are using the category of the Ozempic drugs, and are you seeing issues associated with that? Can you talk about that at all?
So those are my new weight loss surgery patients. So how I would see patients who had weight loss surgery, had it, but didn't work on those behaviors, and then they gained the weight back. Now I'm seeing patients that were on Ozempic to improve their A1C. They improved their A1C. Insurance stopped covering it. They couldn't afford it. Then they gained all the weight back and some. So that's where I'm starting to see now. And I tell people all the time, Ozempic really, really works. It works almost too well. But like, did you work on the behaviors while you were on that? Because if you're just hoping this shot cures everything, it just gives you no appetite. But what happens when your appetite comes back and you didn't work on managing your eating habits?
Interesting.
We have time for one more question. Angelina.
Being a diabetic, I tried Ozempic, and it didn't agree with me. It turned out I had a side effect. Lost 5 pounds in 3 days, but not the right way. So, and then they're trying to put me on Mounjaro, but it's the cost again. It's high, even with insurance. And so I'm seeing that with other people who've had success stories with Mounjaro and other injections. But it comes down because it's a demand for people wanting to lose weight. It's kind of making people with diabetes kind of taking the back corner to all this. And is that what you're finding out with clients that have been on injection type medications?
Yeah, I'm seeing that a lot. Now I can't say a lot because I don't have a whole lot of patients that are on Ozempic or who are trying to get on it. I do have a few that are trying, but insurance denies it because of whatever reason. So they just keep trying and trying. But I have heard that being an issue where someone who really wants to improve their A1C, they're just not able to get it because of the price, or if it's not available, or whatever the case may be. But I have heard those stories.
Well, great. Our guest tonight has been Corey, and Corey Dion Lewis. Thank you, Corey, for being with us.
Yeah,
Health coach at Broadlawns, and he's also organizing the conference on November 15th here in Des Moines. My City, My Health, looking at how we can make the population of Des Moines healthier, with a particular focus on accessibility, health diversity, social determinants of health, and looking at systematically what we can do.
Absolutely.
So thank you for being our guest.
Yes, thank you for having me. This is fun.
This has been great. And if you're watching this and you know someone that might benefit by watching this program, it will be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and also the Mercy One Cancer Center website. I hope you'll join us again next week. Thanks, everyone.